Hi everyone, my name is Rosia and I'm a fifth year medic studying at Cambridge. Just to say that this is part 2 of a 2-part interview series that we've completed to hopefully help you prepare for your Cambridge science or medicine interview. Do check out part 1 if you haven't already before watching this. And as before, I'll also be jumping in at various points in order to give commentary about my performance and what I could have done better.
If I just give you general details first, so we've got a patient who has end-stage renal failure. Please could you tell me how you might think about psychological, physiological, lifestyle factors in treating someone who has late-stage renal failure?
I know that late-stage renal failure can be caused by many things. I think some things that I've heard of include systemic autoimmune diseases, where the body's own white blood cells attack the kidneys, and so the kidneys are no longer able to function. And because of that, the kidneys are really important in getting rid of the waste products in the blood by a system of filtration, and the kidneys are very important to regulating the amount of blood that's in someone's body, because it's able to sense the blood volume and the blood pressure via receptors in the kidney, and that means that the body can control how much water is left in the body. I guess that's not really answering your question, sorry, but the factors that influence how I would treat someone with kidney failure is perhaps the resources available. I think most ideal would be a kidney transplant. Those can be from living donors, where someone donates one of their kidneys whilst they're still alive, and I think that those surgeries have the best outcome. Or it can be from a deceased donor, whereas someone who's recently died has permitted the use of one of their kidneys. And yeah, I think that would be the most ideal, but obviously that requires necessitating going under surgery, and it is a large and long operation. And so if someone was too frail, then I would probably just use dialysis, which is when maybe 3 times a week end-stage kidney failure patients have to go into hospital to mechanically have their blood product waste be removed.
So let's go down the transplant route, which you mentioned you think is the ideal route. Those transplant surgeries their success, which you mentioned, they rely very heavily on the use of immunosuppressant drugs in order to avoid the rejection of the transplant. Can you suggest how those drugs might work?
So the immunosuppressants that I'm slightly more familiar with include medicines such as steroids, and I know that they dampen down the immune response, and that's really important when you have someone else's organ in your body, because your immune cells are trained to recognize any foreign antigens, and they're trained to recognize any foreign material that's in your body, whereas that could be anything from other cells or foreign objects or things that it doesn't recognize as self.
Can you suggest some particular ways that the drugs might work, though?
So I assume that the drugs work by disinhibiting the immune response, and so that could be by reducing the amount of white blood cells, T cells and B cells that are circulating around the body. It could target the centres of those immune cell germination, or the creation of those immune cells, so that the body isn't able to create as many immune cells as usual. This again is a very difficult question which tests your ability to think critically and more broadly. So even if I don't know how immunosuppressive drugs work, I can think about the different components of the immune system that I've learnt about in school. The innate immune system, and we have the adaptive immune system, different cells that operate within each general system of the immune system. There's also other signaling molecules, cells that don't directly destroy the pathogen but actually produce the signaling molecules that tell other immune cells to destroy the pathogen. In the case of an organ transplantation, is actually the cytotoxic T cells which cause tissue damage in the transplanted organ. And so there are lots of immune drugs that target T helper cells which give out signals to the cytotoxic T cells, and when they don't produce those signals, which are in the form of chemical messengers such as interleukins, then the whole immune system is dampened down. You can also think about the individual functions of the cell and how if you stop certain cells from dividing or if you flag them for destruction, that can also reduce the number of cells that are destroying foreign materials in the body.
One of the dangers of using immunosuppressant drugs is an increased risk of cancers. Can you explain to me, firstly, why there is that increased risk? And secondly, how a drug manufacturer or someone designing a drug as an immunosuppressant, what factors they would be looking for to try and reduce and mitigate that risk of cancer. So why is there an increased risk of cancer when you're using immunosuppressants? And two, how might a drug designer try to be very specific in the effect of their drug?
Well, I know that there is an inflammatory response that comes with cancer sometimes, and is that because the cancerous cells in the body are recognised as foreign, and so the immune system actually plays a role in controlling the spread of cancer cells? Or I know some cancers are potentially caused by viral infections such as HPV, which causes cervical cancer. And so if you're immunosuppressed, you're at greater risk of that, or you're at greater risk of other infectious diseases such as tuberculosis, which can also further weaken the body's organ systems and infiltrate the lungs, the skin, which means that the body is less able to support itself, to metabolize its nutrients, and therefore be more susceptible to cancer. This answer was a stronger answer because I realised that there was more than one thing going on in the question, and I mentioned that there is both the direct effects of the immunosuppression on the decreased number of immune cells surveilling for cancer cells, as well as the indirect increased risk of having oncogenic viral infections, which are viruses that can cause cancer. Another thing that I could have mentioned is that some immunosuppressants directly cause DNA mutations, particularly older ones, and this can lead to cancer too.
Coming back to the surgery itself, you mentioned rightly before you need a kidney in order to do the transplant, and there's two, broadly speaking, sources, but you can't just use any kidney that's available, because we want to try and assess whether someone would be a good donor, whether a kidney would be appropriate. What does that really mean, and what biological markers might you be looking for to make that assessment?
So I know that they're very specific and picky when it comes to which kidney someone can use. I know there's some specific markers that they look for. Potentially, well, I know maybe something could be the blood type of the donor, since the kidney deals with a lot of blood. And so if the blood type of the donor is different to that of the recipient, maybe that is a factor that they would need to consider. I'm not too sure what specific things that they look for. I imagine it might be the something to do with the immune system, whether one person's immune makeup is wildly dissimilar to another person's, then the recipient's immune system will be more likely to attack this new kidney.
Okay, and just to give you a slight change of topic now, I'm going to give you a question to ask you to make an estimate using some maths for me, and you can make some notes if you'd like to. Please could you explain to me how you would estimate the total volume of blood in the human body? In fact, not just how you'd estimate it, but how you'd actually try to calculate it as accurately as you could in a particular person.
So if I was given the person's statistics, let's say if we have a 70 kilogram man, I've heard that there is about 70% of the human body is actually water, but we're talking about blood here. So I think mathematically, I've heard that you can inject a solution into someone's circulatory system, wait for that solution to permeate the entire circulatory system, and then you can use a mass calculation which uses the resulting concentration of that solution. Once you've given it enough time to permeate the whole circulatory system, you can find out the final concentration and the initial concentration, and the volume will be, well, the initial concentration divided by the volume of blood would be the final concentration.
So do you want to work that out for me? Just you can pick some numbers that you think are reasonable.
Okay, so if we inject, say, 1 milliliter of dye into your body, and after an hour we can take a blood sample, and it turns out that the concentration of the dye in your body, well, I would probably need to know the numbers in order to make an estimation of that.
Let's say that once the sample comes back, you take a blood sample, and you find that the concentration of the dye in this blood sample is, say you take a milliliter of blood back, and you find that 0.1% of it is the dye by volume.
Okay, so by volume, so then if 0.1% is the dye, then that means if we have 1 milliliter of dye, and that's 0.1%, 1% would be 10 milliliters, then it would be 1,000 milliliters in total that is in the body.
And could you tell me whether you think that's a good estimate?
I don't think it is, because I know that it's not working it from first principles, but I've heard that once you lose about 5 litres of blood, you're basically dead. So that's about 70% of someone's blood volume. And I think 1 litre is...
So you think it's too low?
Yeah.
Could you explain to me, perhaps, let's assume that this error is because there's something wrong with our methodology that we've done. Could you suggest what the assumptions are about this kind of method? What assumptions you're making when you use this method to measure a blood volume?
I think you're assuming, well, if you're injecting a form of dye into the person's body, I know that tissues actually use someone's blood supply, and the blood just doesn't just completely stay constant in someone's body, and your bone marrow is producing red blood cells, and also your kidneys might, the dye might be metabolized and it might end up actually being excreted by the body through the kidneys.
So what, if you formalise that, what are we assuming then about this test?
I think you're assuming that it's a closed system and that the blood volume is constant and there is no change, but there is, and the person might be drinking water or they might be going to the toilet or excreting things.
So those assumptions, does that mean we're more likely to overestimate or underestimate the total blood volume?
I think you're more likely to underestimate it since the dye is being diluted more than it would be otherwise. Actually, if it's diluted more than it would be otherwise, then you probably overestimate it.
Yes, absolutely. So we would probably measure a lower concentration than would be representative if our assumptions were true. And so when scaled up, we would probably find that our volume is higher. In this case, the numbers we've chosen is not.
Right, I'm jumping in to give some comments on this because this kind of question is very common, not just in medicine, but especially in natural sciences and other science interviews. These kind of abstract maths questions where they ask you to estimate something and you just think, I don't have any idea how I'd actually do this. And the key thing to remember with these questions is it's not necessarily about getting the particular right answer. These are questions designed to make you think and to invite you to do some working out. In this instance, Rosia had to be pushed a little bit, even though she had some idea how to calculate it. If you have to make up numbers, do so. You can say that you're assuming a certain thing, but it's about being strategic and thinking logically and explaining that as you do that. This method of injecting a dye and then measuring its concentration once it's been mixed through the rest of the blood is a useful technique to know. However, even if you don't have a particular technique in mind, you have to suggest an answer, even if it seems implausible or that it has practical issues. You need to think and offer something to your interviewers.
Let's put you in a clinical scenario to finish. Being a doctor is not just about having good academic knowledge, not just about understanding the things that you need to think about. You actually have to react to a real situation. So suppose you're on a ward and you witness someone having a heart attack in front of you. What would you do?
Well, I'm not sure how I would know that they're having a heart attack by just looking at them. But if I had the knowledge and I knew that they were having a heart attack, I would definitely sound the alarm and make sure that other people are there helping. I know that it's quite a serious and time-intensive. It's quite a serious condition, and every second matters in terms of the treatment and how quickly you're able to administer that. So I would definitely call for help quickly.
And you say it's a serious condition, it's time bound. Could you talk me through what you understand about the biological process behind it, and therefore why it's serious, why it's time bound?
Well, I know if someone has chest pain, a heart attack is essentially a condition that is acute. It happens very suddenly, and it's when your coronary arteries, which are the arteries supplying the heart, are blocked, whether that's because of a blood clot or whether that's because of a broken piece of atherosclerosis or just a build-up of the atherosclerosis inside the vessels that gets to a point where the blood flow is either severely restricted or completely ended. And I know there's a condition called angina, which lots of people who have heart attacks have had, is when the blood flow is only restricted and not completely restricted. So you get that pain, which is the ischemia of the heart tissue, even though it's not a full-blown heart attack.
And suppose that you have the help around you, and what do you think are the priorities for a doctor in that situation based on what you know is happening inside their body?
Well, I know if they're having a true heart attack and they have no blood supply to an area of their heart, I know it can be a different area depending on which coronary artery is affected, that the treatment that a doctor would want to administer is if the hospital has a centre which can do a procedure called PCI, which is percutaneous coronary intervention, then you'd want to get that patient into the procedural room as quickly as possible. And I think that involves putting a wire through the radial artery into the heart and unblocking that where that blood clot is in the coronary artery, or where that narrowing and blockage of the coronary artery is. And I believe they use stenting for that, so that the vessel is opened so that the heart can have the blood flow to it again.
And following that kind of incident in someone's life, what kind of lifestyle changes might you want to think about encouraging the patient to adopt, and how might it change how you view them as a doctor and their entire the entire landscape of their healthcare?
Well, if they have a stent in, I know sometimes stents can actually cause, or they're already at risk of hypercoagulation because of the narrowing of the blood vessels. Also, an introduction of a foreign body such as a stent can cause even more risks of blood clotting and further cardiac events or even stroke. So I think you would probably prescribe the medications such as blood thinners or antiplatelets in order to prevent the further risk of blood clots, heart attacks and strokes. You would also advise them to exercise more, and also to eat healthier, since I know that atherosclerosis is caused by damage to the blood vessels, either from a really sugary diet, which damages the endothelium of the blood vessel, combined with a diet high in, I think it's saturated fats that are bad for you, and that causes the buildup of atherosclerotic plaques inside the blood vessel. So that is the end of this interview. There are a couple of things I wanted to say about that question in particular. So that was a clinical scenario which I got in my interview. Another thing that they showed me was also a picture of the back of the eye, but we didn't have time to get onto that in this video. But it's very important to look up clinical videos as well before your medicine interview, just in the main conditions that are very common and serious, such as heart attacks, potentially kidney failure, strokes, and watch YouTube videos about them, read about why they are so serious, what's the pathophysiology behind them. Now, 5 years later, I obviously have a slightly better understanding of these conditions than I did 5 years ago. However, I think another tip that I would give you is to carry on practicing interviewing. Ask friends to ask you questions, particularly explaining concepts that you already know. I think even though I had better knowledge about these clinical scenarios now than I did 5 years ago, I think I would have still practiced more, so that I can explain these clinical problems in a more fluent and logical and cohesive way that's less waffly. So thank you very much for watching this, and I wish you the best of luck in your interviews. I am also offering practice interviews, so if you do want to contact me, I will link my website below.